Okay. 5, 4, 3, 2, 1. We all are live now. We can start the session.
So hello all, good evening all. So we are going to start fishbowl, PG fishbowl session and the master class, that is the preferred practice pattern on chemical injuries, cornea, retina and glaucoma. So we are taking up master class on chemical injury and cornea first. Now we are going to do some customary introduction of the JHOS office bearers, and then after the master class of chemical injury and cornea, we will take up fishbowl in the same specialties, chemical injury and the cornea. So now I'm going to, because our lot of activities are related to the academic research committee. So I'm going to introduce our chairman, academic research, Professor Sunil. He is the HOD of Rio RIMS. Please share the slide. And the office bearers, of course, of the Jharkhand Ophthalmological Society. थोड़ा बड़ा करो भाई. Professor Sunil Kumar is Professor HOD, Rio RIMS Ranchi. He is the Medical Director, Government Eye Bank and Chief Cornea Services, Rio RIMS. He has done his MS Ophthalmology in PGI, Senior Residency PGI, and he has a teaching experience of more than 17 years. He has published more than 50 papers in national and international indexed journals, presented papers and faculty talks and instruction courses in various national and state conferences. He has many awards. To his credit, Best Paper Award, COS 2005, Best Poster Award, winner of the AIUS quiz, Dr. B.N. Gupta Endowment Ecoin Award, Isaac State Award, Distinguished Ophthalmic Teacher Award of India, late Dr. R. Singh Memorial Ecoin Innovation Award, Professor Sudhir Kumar Endowment Ecoin, so many Ecoin Awards. And he's the life member of AIOS, Ecoin, DOS, ISOC, JHOS, COS, and CSR. So now, I want, these are the office bearers of Jharkhand Ophthalmological Society. Dr. S.P. Chakanwal is the president, Jharkhand Ophthalmological Society. Sujay Samanta is the honorary secretary. Dr. Bharti Kashyap, myself, they have written wrongly. I am CSC JHOS, and Professor Sunil Kumar is ARC JHOS chairman. Dr. Malay Verma is honorary treasurer JHOS. So now over to Dr. Sunil Kumar for introduction of the moderators, Dr. Shweta Walia and Dr. Bharti Kashyap.
Yeah, so thank you, ma'am, and good evening, everyone. So I will introduce the moderator of the today's session. So
first, share the slides. First, share Shweta Walia's slide.
हाँ भेज दिए. बड़ा बड़ा करना, इतना छोटा क्यों कर रहे हो?
Please mute other one.
Premlata, please share the slides. First, share the Shweta Walia slide. Actually, yes.
Yeah. So Dr. Shweta Walia is the professor, MGM Medical College, Indore, and she is the chairperson, Scientific Committee, MP State Ophthalmic Society. She is also the chairperson, Scientific Committee, Women Ophthalmological Society. She is Central Zone Representative, OTSI, Central Zone Representative, IS, MICS, and she has to her credit more than 50 publications in national and international journals and contributed chapters in Hindi ophthalmology textbook. That is one of the initiatives in which Madhya Pradesh has taken national lead. And she has innovated technique of the sutureless, glueless SFIOL 2016. She has many awards like All India Talent Search Award by the then Prime Minister of India, Sri H.D. Devgoda, Best Teachers Award, and so many awards. So I welcome Professor Shweta Walia to moderate the session. Yeah.
Thank you, Dr. Sunil and Dr. Bharti for honoring. Thank you so much.
Yeah.
Thank you so much.
So next moderator of the session is none other than Dr. Bharti Kashyap. So she is the founder director, Kashyap Memorial Eye Hospital, medical director, Kashyap Memorial Eye Bank, and she is specialized in the femto cataract and refractive surgery. She is chairman scientific committee of our JHOS, and she is also the chairperson of Women Doctors Wing IMA Jharkhand. She is secretary Women's Ophthalmological Society Jharkhand, and she is also the organizing secretary of our upcoming midterm conference of the All India Ophthalmological Society. And she has so many awards to her credit, and most important is that she has received the Nari Shakti Puruskar Award from the then Honorable President of India. So there are so many awards. So I welcome Dr. Bharti ma'am. for moderating the sessions. Thank you. So
it's enough. And now you please introduce our guest faculties.
yeah, sure, ma'am. Sure.
We are sharing the slides from here.
Okay.
First, Dr. Varsha. Dr. Shweta Walia is all done.
Yes. So, good evening. So, Dr. Varsha Bhambhani, she is the consultant cataract, cornea, and ocular surface services, Sankara Nethralaya, Chennai. See, the clinical and research interest include the dry disease, ocular chemical injuries, and Stevens-Johnson syndrome. She is the author of 15 plus publications in PubMed Index peer-reviewed journal, and she has contributed to 5 book chapters in ophthalmology. She is the regular faculty speaker and presenter at national and state ophthalmic conferences, and she is also the co-founder of the Ocular Surface Gurukul, which is an educational YouTube initiative dedicated to ocular surface disorder, featuring 50 plus academic videos. So welcome Dr. Varsha ma'am as a guest speaker and the expert of this session. So the next expert is again Dr. Professor Sweta Walia. We have already introduced. Next is the Dr. Nivita Narayanan. She is the Deputy Director, Accreditation, Safety and Quality Assurance. She is the Senior Consultant, Cornea and Refractive Services, Medical Research Foundation, Chennai. And she is passionate about the lamellar corneal surgery, cataract and refractive surgery. She has a strong commitment to advancing surgical excellence. She has actively participated in and conducted numerous surgical training programs and workshops, and she has presented clinical and research work at national and international conferences. She has published research in peer-reviewed scientific journals, and she is the recipient of the awards and recognition for excellence in the clinical work, research, and scientific presentation. So, welcome, Dr. Nivita ma'am, as an expert of these sessions.
Thank you very much for the nice introduction.
Yeah. The next expert is Dr. Charuta Purnik. She is the Senior Cornea Consultant and Founder Director, Ocular Generous Biotech Private Limited. She is a fellowship-trained cornea and ocular surface specialist with expertise in the medical and surgical management of the ocular surface disease, corneal infection, keratoplasty, and complex cataract surgery. She is the Founder Director of the Ocular Generous Biotech Private Limited and serves as a Senior Cornea Consultant at Medivision Eye Hospital, Hyderabad. And her advanced training includes the long-term cornea fellowship at LBP Eye Institute and international training in ocular surface regeneration at the Kyoto University of the Medicine, Japan. And her clinical and academic work focuses on the interface of inflammation, infection, and immunosuppression with a strong emphasis on the antibiotic use,
Dr. Sunil.
early escalation.
Dr. Sunil, it's enough.
This is all
it's enough. So now we are beginning the exciting and academically rich, enriching session on the preferred practice pattern in acute and chronic chemical injuries and cornea. And we are truly privileged to have with us with our eminent national faculties like Dr. Varsha, Dr. Shweta, Dr. Nivedita, Dr. Charuta, who bring immense expertise and experience in the field of chemical injuries and the cornea. So what makes this even more special is that they are also experts in our PG Fishbowl session on chemical injury and cornea session, and highly interactive and dynamic learning platform. So now I over to Dr. Sunil to quickly introduce the chairpersons, the one-line introduction of the chairpersons who have joined. We have already shared with you the chairpersons of the master classes of the chemical injury and chemical injury. Over to Dr. Sunil.
Okay, ma'am. Yeah, okay. Thank you, ma'am. So I will briefly introduce all the chairperson of this session. So first, none other than Dr. P.P. Kashyap. He is the organizing chairman of our forthcoming AIOS midterm conference, Ranchi, and is also the past president of the JHOS and ex-MC member AIOS. Next is Dr. Vibhuti Bhushan, is the vitreoretinal phacosurgeon and director of the Vishnu Nethralaya, Jamshedpur. Dr. S.K. Mitra, again consultant ophthalmologist from the Jamshedpur. Dr. Rahul Prasad, additional professor, Rio RIMS Ranchi. Dr. Ajay Gupta, senior consultant at Rasmi Eye Care, Jamshedpur. Dr. Vandana, Ranchi-based senior ophthalmologist. Dr. Mayuri Bhattacharya, again senior consultant ophthalmologist, Ranchi. Dr. Dolly Tandon, senior consultant ophthalmologist at Ranchi. Dr. Pritish Parnay, senior consultant, Sadar Hospital, Ranchi. Dr. Abhishek Sinha, senior resident, Dhanbad Medical College, Dr. Ankit Gupta, oculoplastic surgeon from the Dhanbad, and Dr. Mohit Biskarma, senior resident at TMH Hospital, Jamshedpur. So I welcome all the chairperson of this master class on the chemical injury. So thank you.
Now over to Dr. Varsha Bhambhani for her didactic lecture. Please share your screen. Cornea वाला का कौन करेगा? Madam, please share your screen.
Yeah, ma'am. I'm just sharing my screen.
Yeah.
One second. Is my screen visible now?
Yes, yes.
Yes, visible.
So, very good evening, everyone. I am Dr. Varsha Bhambhani from Nethralaya, Chennai. And I can continue.
Yes, ma'am, continue.
So, at the outset,
Dr. Bharti, please mute yourself because there are a lot of disturbance from there. Please go ahead, Dr. Varsha.
So at the outset, I would like to thank Dr. Bharti Kashyap ma'am for inviting me to deliver the guest lecture. And today my topic is surgical management of acute ocular chemical burns. In view of time, I would be presenting this with the help of some clinical case scenarios. So as we all know that ocular burns is a true ocular emergency, and the long-term visual rehabilitation actually depends on how well these are managed in the acute phase. The primary goals in essence are two. First is to remove the inciting agent and stop the ongoing insult that is happening to the ocular surface. And the second is to restore the ocular surface by promoting rapid epithelialization. And to do this, we have to address surface inflammation, intraocular pressure, ischemia, and exposure. So the most important thing in this is irrigation, the removal of the offending agent. The irrigation has to be immediate, it has to be copious, and ideally the irrigation has to be started at the site of the injury without even waiting for the patient to reach at the eye care hospital setup. Eversion of the lids and inspection of the furnaces is more important to identify and to remove any kind of residual chemical that is there. What is the choice irrigating solution? What is the choice of the solution? So these are the various irrigating solutions that are available, from tap water to balanced salt solution to ringal lactate, normal saline, taflotarine, and sideroth. What should be preferred? So the most effective irrigating solution actually depends on the pH and the buffering capacity of the solution. And diphotarine and sideroth are equivalent, followed by BSS, RL, NS, and tap water in that order. But what we should understand is that prompt irrigation is more important than choice of the irrigating fluid. So rather than waiting for an effective irrigating fluid, rather than tap water and on-site irrigation is more effective. How this is done? So minimum 30 minutes of wash which is what recommended. We should be doing it with 1 to 3 liters of irrigating fluid. We should ideally check the pH in the beginning and after that every 15 to 20 minutes. Also, we should check the pH 15 minutes after finishing the wash to be very sure that the pH that we are checking was of the eye and not of the irrigating fluid that we were using. And these are the prerequisites: a litmus test, a litmus paper, a irrigating solution, a kidney tray, and an IV set. That is all which is needed for a proper irrigation. Medical management, as we all know, involves broad spectrum antibiotics, cycloplegics, topical steroids, and I will not go into detail of this. Surgical management, it involves removal of the inciting agent, AMT or alloslet for promoting epithelialization, tenonplasty to address the ischemia, and tarsography or skin graft to address the exposure. So skip this. Let us start with the cases. So this is case 1. This was a 34-year-old male who was a bystander for a carbide gun injury. On presentation, he came to us with the vision of 1/60 in the left eye. It was a grade 1 DUAS injury. As you can see over here that you can there are residual carbide particles, calcium carbide particles in the cornea as well as over in the conjunctiva on the left side over here, and a small central epithelial defect. So for this patient, we went ahead and did an EDTA chelation. And for the EDTA chelation, we took the patient up in the operation theater. As we took the patient up in the operation theater, we also did a amniotic membrane and onlay with the purse ring sutures. This is 6 weeks post-operatively, and you can see how clear the cornea is. This is 6 weeks and this is 6 months, and the patient vision improved to 6/7.5. This is a second case of a 17-year-old male who had a Chuna injury because of the blast at his workplace, and he presented to us with the vision of 6/18 in the right eye. The IOP was slightly on the lower side. The white 80 was 4. As you can see, there was a corneal defect with the surrounding conjunctival defect. These are the impacted Chuna particles over here, and in the fornix, ocular surface inflammation. So if we grade this injury, it is a DUAS grade 2 injury. What DUAS does not see is the amount of the tarsal defect, the pressure, the ischemia, and the exposure, which is covered in the new classification, that is an EPICS classification. And if by that we go, this is an E2, P0, I0, and X0, which is still a grade 2 injury. So for this patient, we went ahead with the debridement and a patch, that is an inlay AMT with the fibrin glue. And this is 2 months post-op, whereas best corrected visual acuity improved to 6/15. You can see that there is still a little bit of inflammation at this site, which had an impacted line. This is 9 months post-op and his vision improved. The corneal clarity also improved and the surface is now completely quiet. The third case is of an 18-year-old male, again carbide gun injury. He had undergone an AMT and a symblepharon release elsewhere. He was on topical steroids, glaucoma medications, atropine, antibiotic, Ocupil, and even oral oral steroid 6 milligrams TDS. On presentation, his vision in the right eye was hand movements, and the finger tension was slightly on the softer side. So at that point of time, we had stopped his topical AGMs. This is the presenting picture. Now, if you see, there are still certain carbide particles which are fine carbide particles over here which are impacted in the cornea. Your corneal defect is very small, approximately 4/5, but if you carefully look, this is all conjunctival tissue. So this is a patient which has a significant limbal stem cell deficiency, as he had undergone amniotic membrane twice elsewhere. When we took him up for an EDTA chelation because still there were particles in the eye and with alloslit. This is post-operative picture, 2 months, wherein at this point of time, because of the significant corneal stromal haze, the uncorrected visual acuity was 1/16, but it was improving with the scleral lenses to 6/15. You can see how the eye is quiet. These are the slit bits that you can see on the cornea, and you can see that there is no defect and the surface is well epithelialized. And this is post 4 months, wherein his uncorrected visual acuity is 6/36. You can still see that these are some deep particles which are there, which over a period of time, what we have observed, remain inert and they do not actually perpetuate inflammation, and the eye remains quiet. You can see how the surface and the eye has quietened down over a period of time. This is another case. This is again a 34-year-old male who had an acid injury, accidental injury at home, and he had presented to us with a severe grade 6 DUAS. You can see there is total 360 degrees of limbal ischemia, corneal opacification over here, total corneal and surface defect. The finger tension was high. His vision was hand movements. So on EPICS, if we, on DUAS, it's a grade 6 injury, but what in addition to the grade 6, the EPICS classification tells us that it actually forces us to look at other factors like intraocular pressure, ischemia, and the exposure, which also need addressal in the acute phase management, and which actually have an indirect effect on promoting epithelialization of the surface. So as you can see, P plus denotes that the intraocular pressure was abnormal in this patient. It was on the higher side. So we had started the patient on topical AGMs. You can see that it is I2, which is a grade 2 ischemia, and then it shows that this needs attention and this needs probably some surgical management. And he also had a little bit of lag of ophthalmos and that is an exposure which is X1. So the surgical plan for this patient was tenonplasty, alloslet, and tarsography. I'll just share a short video of the surgery and the surgical steps. This is how we do the tenonplasty. We separate the good conjunctiva from the underlying tenons and from the underlying sclera. The dissection is done with the help of a scissors, and it should be deep into the fornix because the idea is to pull a vascularized pedicle over the ischemic part of the sclera. Now, this pedicle has to be thin. If the dissection is very bulky, then there is a tendency that it will retract back. The dissection also should be carried out deep into the fornices, as deep as possible, so that when we are pulling it near the limbus, it is free. This is secured in place with the help of a fibrin glue, and then it is anchored, augmented with anchoring sutures with 7O vicryl. Similarly, it was repeated on the superior side also, as it was a 360 ischemia. And this was followed by alloslet. Alloslet and not an AMT in this case because of the significant loss of the conjunctival epithelial cells. So AMT is a basement membrane. It does not have epithelial cells. So we have to supplement the surface for extra source of an epithelial cells for it to epithelialize faster. And this was followed by BCL and a tarsography. So this is post-operative. As you can see, 6 weeks at GA, you can see a completely epithelialized surface, no defect, a quiet eye. So here what we have done is it was a grade 6 injury, and with the surgical manifestation, the aim of the management is that all the E, P, I, and the X should come to 0. So here there is no defect. The pressure was controlled with Combigan, the ischemia was addressed with tenonplasty, and the exposure was addressed with the help of a tarsography. This is the pre-op, this is the 6 weeks, and this is the 6 months post-op. Again, another case of a grade 6 Duas injury. Now, this was a young male who had a tuna thrown at him by one of his friends. And in this, again, this is grade 6. As you can see, there is an impacted line over here, a complete 360-degree limbal ischemia, total surface defect. So the plan again was, along with doing a tenonplasty and alloslet, this also requires debridement or removal of a line plug that is there, and in addition to that, a lamellar keratoplasty. So the pressing concerns are over here are the line plug in the cornea that needs to come out, 360-degree of scleral ischemia that has to be addressed with the help of a tenonplasty, and 80% of the bulbar surface defect for which an alloslet was planned. There was also significant intraoperative scleral thinning, so we also did a scleral patch graft in this patient. This is a short video. A peripheral groove is made and layer by layer dissection of the cornea is done. You can see the line plug coming out. We try to avoid a full thickness keratoplasty in these patients because the outcomes are not that great. So a lamellar keratoplasty is always preferred. And if you feel that there is some line which is still there on the desmids or the near desmids, you can always use an EDTA intraoperatively. Before using that, we can always use a litmus paper and check the pH. And if it's again on the alkaline side, then EDTA chelation can be done. This is the scleral patch graft that is done for the thinning, and the sutures over here involve the cornea and the patch graft, which was followed by the tenonplasty superiorly and inferiorly. As you can see on inspection, this is a full line plug that is still embedded in the conjunctiva and in the fornix. So this needs to come out. So a good intraoperative eversion of the lid and inspection is also mandatory This is how we just go ahead and remove the lime plug because it's a fill. The chelation won't work here, so it has to be surgically debrided so that lime conjunctiva with an embedded line is separated from the underlying healthy tenons tissue over here. And this is followed by the alluslet. So the AMT was covering fornix from the superior fornix to the inferior fornix through and through, and the slet bits were put on the cornea as well as on the perilimbal conjunctival area also. So this is 2 months post-operatively. This was his pre-operative, you can see, and this is the post-operative picture. Well epithelialized surface, a quiet eye, and a salvaged globe. This is my last case, which is very special to me. She was a 12-year-old female who presented with a firecracker injury, very uncooperative. She did not allow any kind of examination in the OPD. So we took her up for an examination plus minus additional procedures in the operation theater under general examination. And as you can see, she had a significant periocular burns as well. The right eye was a little better eye and only had a small defect, which just resolved with the help of the topical medical management. But the left eye had significant injury. You can see this is the ischemia had a corneal defect. Almost a little bit of limbus superiorly was saved. You have the soot particles on eversion over here, as you can see, and you can see this is all tarsal ischemia also. So this was a grade 4 duas and an EPICS, which allows us to grade the conjunctival, the corneal, and the tarsal defects, the pressures, the ischemia, and the exposure. So the patient was planned for a soot removal, a sectoral tenonplasty, and an amniotic membrane. This is how the intraoperative picture looks like after the tenonplasty and the AMT. And to take care of the periocular burns, every day the Bactigras dressing was done and the patient was co-managed with the help of our oculoplasty colleagues. So it is very important that these patients need to be managed across multi-specialities. This is how this is post-operative 3 weeks. Superiorly, we can see it is well epithelized and the retained matter, even the blood vessels have started coming in over here also, but there is a little bit of an area which is still ischemic. So we took her up again for a revision tenonplasty, and this is how 4 months later you can see it's a well epithelized surface, clear cornea, a little bit of a focal limbal stem cell deficiency, which you can still see on the fluorescent stain, but otherwise the vision improved to 6/9, and here you can see the periocular burns also have been managed very well. So this is our channel Ocular Surface Gurukul, which has all the videos and many more videos, academic videos. You can log into it and you can see. Thank you so much. This is our team at Shankar Nethralaya, myself, Dr. Shweta, and Dr. Mukundan. I'd like to take an opportunity to announce that we are hosting at Shankar Nethralaya Ocular Surface and Keratoprosthesis Conference, which is in July 23, 24, and 25 next year, not this year, that is in 2027. And it's the theme of the this year's conference is one surface, many disciplines, taking the patient through many specialties. I invite and welcome all of you, whoever are interested. You can contact me. The website will go online in few months, and I welcome you all to join us in this Ocular Surface Specialty Conference. Thank you so much.
A very nice representation of your surface team, and I really respect the team. So thank you so much. So you have to stay connected because you are there in the fishbowl chemical injury also. Over to Dr. Shweta Walia for the chronic chemical injury management. Please share your slides. Yes.
Thank you, Dr. Bharti, for giving me this opportunity to present on ocular chemical burns, complications, and sequelae. Though the topic has been very well covered by Dr. Nivedita, and it was like though they were doing acute management, they have to follow the patient long term because the patient needs multiple interventions so that we can give a wonderful outcome to the patient. So you can see over here that this is a patient who had a pneumonia injury, industrial injury, and day 14, it was grade 6. And though he survived the acute phase, but in 3 months, we were still facing the sequelae. There was ischemia, there was corneal opacity, and vision was less, and the patient needs a sequential management. So what is the biggest challenge in chemical burn sequelae? It is persistent epithelial defect. There is limbal stem cell deficiency. Corneal melting, corneal scars. There can be symblepharon, there can be entropions. There is intractable dry eye, and most commonly and the unneglected one is the secondary glaucoma. So this is a patient who had persistent epithelial defect with limbal ischemia at 3 months. And the main aim was to halt melting and epithelize the surface. So what do we need to do? We need to be aggressive in lubrication, give preservative lubricants to the patients. We can also give autologous serum to the patient, and we usually give 50% autologous serum to the patient, and it has wonderful effects. We can also go for amniotic membrane grafting and combine it with a slit. We can go for tarsorrhaphy, and scleral lenses is one of the things that is gives wonderful results in such patients. It gives a normal equilibrium to the cornea and heal. So the pros lenses, that is the prosthetic results, though cost is a big issue. In India, they cost about 35,000 to 45,000 per lens. The diameter of these lenses is 15.5 to 18.5 millimeter diameter. It also prevents rubbing of the lids onto the cornea and provides a normal equilibrium to the cornea to heal. So how do you diagnose limbal stem cell deficiency? In early phase, acute phase, it is very easy to diagnose it. But in late phase, how do you see it? So this is the normal healthy limbus. You can see the both palisades over here at the limbus. And in end stage, there will be loss of these palisades. There will be conjunctivalization of cornea. And when you do fluorescein stain, you will see a typical fluorescein whorl on the cornea. So how do you manage such patient? The step 1 is conservative management with preservative-free lubricants. If it is mild or partial limbal stem cell deficiency, autologous serum, as we discussed, is a wonderful option. We can proceed to stem cell grafting. If it's a unilateral total stem cell deficiency, slit or cultivated limbal stem cell transplant or CLAW, that is conjunctival limbal autograft, gives wonderful results. But if it's a bilateral total stem cell deficiency, you have to go for keratolimbal allograft or a cultivated mucosal epithelial transplant, but these require systemic immunosuppression. So before we proceed to anything, we need to fix the environment. So what do you need to do? You need to do the adnexal correction. In this patient, you can see extensive symblepharon with ectropion. So you need to release this symblepharon, reconstruct the fornix, and if it is entropion, you need to correct the entropion and also take care of the trichiasis. So if the adnexa is not corrected before, all our attempts to epithelize the cornea and prevent limbal stem cell deficiency all goes to waste if adnexal is not corrected. This is another case of a patient with large ptosis, and we did tarsal rotation for this patient and corrected the large ptosis. The another problem in sequelae is that the cornea is opaque. So in this patient, what will you do? Whether will you observe to give a ocular surface reconstruction, or you will go directly to the penetrating keratoplasty. So the idea in these patients who are having limbal stem cell deficiency, first is to go for stem cell transplant. So this patient I showed you earlier, this was having a persistent epithelial defect with a limbal stem cell deficiency, and we managed it with a amniotic membrane grafting with a slit, and you can see that after 6 months of follow-up, the cornea had begun to clear out. So we had developed our new technique of doing
technique of modified techniques.
in which we put multiple chains, each type of sutures. And the only care that you need to take is that the second part to behind, slightly behind the first part. And in the end, you open up all the loops, and as you put the suture, all the suture is buried underneath. Let's see in the patient's eye. So we start to do chain stitch, taking care that the next pass is just starts behind the first pass. And in the end, we open up all the loops. As you pull the suture, the entire suture goes underneath the amniotic membrane. And you can see how snugly amniotic membrane is fitting onto the patient's cornea, just like you have used glue. So this is the second case. You can see the stitch. This is a modified technique of doing suturing in amniotic membrane, and it gives results similar to the glue. Whenever we are deficient of glue, we do suturing in this technique. So now, as I told earlier, that if you do grafting, keratoplasty in a hostile environment, the ultimate result is epithelial breakdown, stromal melt, deep vascularization, and an aggressive rejection. So you first need to stabilize the ocular surface and then proceed for a keratoplasty. So this is our patient of chemical injury in which there was extensive corneal opacity, and we went for a slit. And after 3 months, you can see the central cornea has begun to clear. And for this patient, we actually didn't require to do penetrating keratoplasty. And we have found over years that in such patients, slit had reduced our need to go for penetrating keratoplasty. For other remaining patients who are having end-stage disease and the only ultimate treatment is keratoprosthesis, though we are not doing keratoprosthesis, we are referring the patients for keratoprosthesis. So first thing is to do adnexal and eyelid stability, do tear film restoration, then go for stem cell restoration. If there is corneal opacity, proceed for DALK or penetrating keratoplasty, and finally visual rehabilitation. The only thing that is missed many times is the glaucoma, which is responsible for delayed healing in 22% of the cases. And this must be kept in mind whenever we are dealing with the chemical injury patients. And when the vision, nothing works, no PLIs, evisceration with orbital implants gives wonderful results. And this is one of our patients who had no PL. And we did evisceration with implant, and you can see the outcome and the happy patient. So what top 5 mistakes we should avoid is grafting before stabilization of the ocular surface and stem cells, missing subtle peripheral signs of limbal stem cell deficiency, ignoring minor symblephrons and entropion that can cause mechanical friction, under-treating severe toxic dry eye environment, and delayed referral to a tertiary ocular surface centers. If you feel you are not going to able to manage the patient, better refer it to a higher center so that he gives a good rehabilitation. This is the patient of one of our patient, Mukesh, and after 2 years, he has some amount of vision so that he can do his routine work. So the success of chemical burn patient is not measured by the healing of the burn, but the restoration of the stable ocular surface. And I had done my PhD in ocular chemical burn, and it started in 2019, and because of COVID got delayed, and this year only, I was got my degree in PhD in ocular chemical burn. Thank you so much for listening to me. Thank you, Dr. Bharti.
Thank you so much. Thank you so much. Please stay connected. And
one question, please, if I can ask to Dr.
Yes, ma'am,
Dr. Shweta. Very nice presentation, Dr. Shweta. And the amniotic membrane graft. When do you normally, what is the time which is taken when we do the amniotic membrane grafting? Normally, how much time does it take when we do it?
So if you find that the cornea is not starting to heal in 7 to 10 days, then in acute phase also we have started doing amniotic membrane graft, and wonderful results.
As early as possible, within a week, results.
correct.
And where do we get autologous serum eye drops?
So we in our hospital, I'm in medical college, and over there we are using autologous serum for past since 2004 we are using it, and actually it has gone into our practice only. Whenever we see that we are not getting results with the artificial tears, we take blood sample of the patient, send it to the pathology department, they centrifuge it, take the serum, and they send it to us, and we dilute it to 50%, and we ask the patient to keep those drops in refrigerator or in a cold environment, and we give multiple bottles to them. One bottle is kept out and rest of them is kept in refrigerator, and we usually dilute it with artificial tears only. We don't dilute it with normal saline.
Means that 10 ml, if they give you 10 ml of serum, you dilute it with 10 ml of artificial tear.
Yes, ma'am. Yes, ma'am.
So what artificial tear you use for the dilution? Which one?
Yes, artificial. Normal carboxymethyl cellulose.
Okay.
Okay.
So any question for the acute injury for Dr. Varsha? So we can take up the questions later also.